Next we have another team presenting, Emma Jordan, who's a nurse educator at Taranaki DHB, and Jonathan Albright, who's an intensive care specialist.
Thank you very much for inviting us to speak today. We're here to talk about our Taranaki experience. We're a smaller DHB, we're a reasonably small size hospital, a population of 118,000. With 239 beds that we're resourced for, and we have 13 first year doctors. I've been working with junior doctors on patient deterioration for about 5 years, and so I think that gives me a role in describing what it was like before and the changes that this chart made for us. We had a chart, scores were not done routinely, escalation was very sporadic, and it was very frustrating because you could look back through the charts and you could see if only this had occurred, and this was a constant theme that we had. But we'd made a lot of efforts in this regard. We had a resuscitation committee. We had a hospital mortality review that was looking at these issues. We'd developed an education program for our junior doctors. We'd looked at serious events and tried to put these directly into the teaching. And we started with simulation and then simulation in situ between nurses and doctors. But we just weren't really getting across. So we did grand rounds on this topic. We went to departments. Our hospital's very lucky that 3 or 4 times a year we have a whole hospital sit-down triple M&I meeting where all the senior nurses, the nurse managers, physios, the line managers, the junior doctors and the senior doctors sit for 90 minutes and discuss one case looking at system improvement. We also audited what was happening, and we could show that there was a real problem, but we just weren't getting traction in terms of getting these patients seen and sorted. I had been working with the resuscitation coordinator for 3 years, and it was quite frustrating because I'd built a relationship with this person and they would resign at the end of the year. To carry on an earlier theme, the third one was having a baby, but it wasn't my fault. What really worried me was I felt that these people, they knew what the issue were and they were driving, but they weren't getting any traction with senior management that this was important. It was important because everything's important, but we just don't have the money and we've got a lot of things to do. We also have an open ICU HDU, and every year we close it a little bit more. We've added 4,000 ICU hours this year to our ICU. We still don't have a patient at risk team. And we had the scenario that other hospitals have where our shift coordinator is also the access nurse, also has a patient, and is also going out to attend arrests. So we didn't come in with a PAR team straight away. We didn't have a director of nursing. It was a job share where somebody covered it. So our nurses weren't as empowered as they could have been. And we had a lot of staff turnover. People were coming and going, and every year it seemed like we were losing more and more senior nurses that really, in our hospital with no senior registrars, are the most important people after ours.
So I was the next person to come on in as resource coordinator this year. I missed out on the planning, but there was a lot of planning that went into the implementation of the EWS and rolling it out as a system and making our systems work so that it would actually get off the ground. So we had to restructure the governance a little bit. We had a resuscitation committee, which, in order to have good oversight of our EWS system, the terms of reference were expanded to include management of the deteriorating patient. We also had an EWS steering group created as a subgroup which met monthly. And we had really good leadership within these. We had the Director of Nursing and the Chief Medical Officer, Jonathan as the clinical lead, and myself, and resuscitation coordinators before. We also adapted, or pretty much remodelled the EWS policy and added in EWS to the resuscitation policy in order to make that work. So once all of the policies supported the change, we
Sorry. I went the wrong way.
So yeah, once all the policies and things supported the change, we went forward with the rollout. We used the resources that were provided, and we also made some of our own. We allocated a specific nurse. Not every area in our organisation has a nurse educator assigned, so we've just got some areas have educators and some don't. ED didn't, etc. So, but every area had a nurse educator assigned to manage the rollout, to allocate the resources and to do the education, so that someone was accountable, so that each area which it was rolled out into couldn't say that they had no education. So we aimed for consistency. We had it rolled out into not only our eligible wards, like the medical, surgical, rehab, but we also implemented across the board adult wards, so ID, ICU, ED, and mental health. What we also did is, before we rolled out the EWS, a deteriorating patient study day for nurses was created, and this is now our biggest attended study day for nurses to date. We're still seeing upwards of 40-something nurses attend each day as we go through, and we're having them 4 to 6 times a year since the beginning of last year, which is quite exciting. And so these are covering assessment, systematic assessment of the deteriorating patient, handover, cause and escalation, causes of patient deterioration, and end-of-life care in relation to the deteriorating patient. And we've also linked our EWS systems into orientation for nurses and doctors. So just like everybody else, we did our auditing. We run a paper-based auditing system. We did the 10 audits a week for every eligible area, and initially these were sent back to the resuscitation coordinator. But when I came in, I found that there was a bit of a drop-off of them coming back, and so therefore oversight was kind of getting lost of what was going on. So what we did, I don't know whether that was because they didn't know me or what was going on there, but something needed to happen. So we gave the oversight back to the clinical nurse managers and fed the data straight back through the clinical nurse managers. I still got the audit data at the end of the day, but what it meant was that the clinical nurse managers were really owning that data for the areas and being able to implement changes in response locally at their level. Any audit results, I also reported back to the EWS steering group, and we were able to troubleshoot any problems that were sort of bigger than ward-based. So things like modifications or things like that we couldn't tackle in one place. I also was out there pretty much 2 to 3 times a week, just spot auditing charts, and that was sometimes frowned upon by the ward nurses, but it's actually been really good just to have that real personal level, getting out there and saying, hey, this EWS is whatever it is, what are we going to do about it? And that's actually had a really good response. They know me, they know what it's for, and yeah, we'll just keep going with that as well.
Thank you. The next thing I wanted to talk about was working with doctors, which I've broken down into resistance, resentment, and defiance. I expected some resistance beforehand, but nobody read it or read the posters or the emails, so people didn't really know it was coming. People thought this was a form of managerial control, and I think some of my senior colleagues are sort of ex-hippies from the 60s, and they really do think the man is going to get them. So it was nice to alleviate that. Some other examples were an orthopaedic registrar saying to a nurse educator, "I can't put a screw into a pneumonia, so I don't want to know." That's a real life quote. But also that the team that day just stood kind of behind him like this, like, whoops, like, he's got a point, you know. So that was a little bit traumatic. And there was a bit of support for that person. One of my colleagues wrote me an email of outrage that they were very important and I hadn't individually consulted them. So I wrote back, "I'm sorry you missed the posters, emails, workshops, reminders and grand round. We did not deliberately intend to exclude you. Your input is most welcome." And they actually did make a useful contribution. And the last one was the things you never expect. So this is a variation. I've rewritten it for anonymity's purposes, but the duration was forever. So that made me think some people weren't taking it too seriously, but yeah, or maybe they just were very used to early 2000s tech speak. But a lot of doctors had really genuine concerns, and we were able to go to them as groups, and they would say things like, "You're taking away the house surgeon's learning." And I said, well, actually, the house surgeon still learns, they still find out, but that patient might be dead tomorrow, and there's a 10% chance of that happening, so it's not just an educational opportunity. And usually by focusing on what we're trying to do for the patients, people came around pretty quickly. Yeah.
Quickly. So, turned out that what we were doing was actually making a difference. So in 2016, we had a 57% pre-arrest call rate and a cardiac arrest up around the 43%. Looking back at the data, it was actually relatively good data collection. Going forward in 2017, it's slightly improved, and then this year's just been astounding, with a huge drop in cardiac arrests and increase in pre-arrests. One of the most exciting, I know this is a little bit graphy, but our surgical ward, which is up there as 3A, has had a huge rise in pre-arrest calling over the past 3 years. But particularly this year, and this year with the implementation of, well, I'm attributing it to that, EWS is down to no cardiac arrests. And so we're seeing that dribble out to the rest of the wards as we go as well. So what made the difference? I think we really just ran with what we were given. HQSC had given us this national directive, so it wasn't something that we were picking up and going, okay, we're going to make a change for the sake of change. It was something that was evidence-based, it was prescriptive, we were well-resourced, and it was monitored with auditing feedback to the Commission, so there was we had that backing to really roll it out with gumption. We had our deteriorating patient steering group was really well led in terms of similarly to the last group, we had a real top, we had support from the top. Our audit results, we were able to overcome any hurdles together and really get out there as a group to make a difference. So going forward, we are implementing our PAR nurse role. This is coming in January. We've had a nurse educator specifically seconded to develop the role and the escalation pathway specific for our DHB. So interviews are January 9th if anyone's looking to move to Taranaki. We've also had a project running the second half of this year to improve communication within the DHB, so we've implemented ESPAR, which is actually doing all right, I'd like to think, and we are we've implemented a deteriorating patient study day for nursing leadership, just to have that secondary support, because with our deteriorating patient study day's gone off so well that we thought one for the next level up is a really good way to just embed that further. Sorry, I've gone over time. But yeah, we'll continue with kōrero mai and shared goals of care. And I didn't get to talk about our simulation centre, but we're looking to redevelop an old ward to go forward with deteriorating patient education as a multidisciplinary interactive training centre. Thank you.